opinion unrestricted. The way we get our questions are really threefold. One, they come through Cabinet Office. So there's a formal commissioning process whereby questions will come into Sage of matters that the Cabinet, or in the case when COBRA is stood up, COBRA would wish to know the answers to. The second is that it can come through departments. So, for example, on aspects of information around schools and COVID, it might have come directly from the Department for Education with specific questions. They still go into Cabinet Office, but those questions will come from a department into Sage. And the third is that, of course, we ask our own questions, and very often topics will come up that we think are important, that need to be looked at, sorts of ones that have been ones that we've pursued quite heavily during this around immunity and immunology, where we've asked questions which are highly unlikely to come from Cabinet Office, but will come from members of Sage and from our own work. Questions around the science of transmission, which again, I think are things that we would drive ourselves. And we also, for example, set up a working group on nosocomial transmission and care homes and so on, which would be things that we would set up ourselves rather than wait for a question to come from Cabinet Office. So those are the three major routes by which questions come into Sage. And Sage will either deal with the questions itself as a group, but more often the questions will go to subgroups of Sage, and we have a number of subgroups populated largely by academics from different backgrounds, which range from modelling to behavioural science to specialists coming together to tackle problems on transmission, to clinical groups and others, including genetics and so on. So there are a number of groups that would look at the questions. In terms of the feedback, the way it works is, of course, that when we meet as Sage, either I or Chris or others occasionally who've been in meetings will give a general commentary at the beginning of the meeting and a situation update where some of the outputs and how they've been used may be discussed as part of that. And the chairs of the subgroups are all on Sage and therefore are in a position to feed back to their subgroups where appropriate, anything that's relevant to the work of that subgroup. So in outline, that is how Sage works, and we get our questions. I may just, if I may, just ask whether Chris wants to add anything, because he's obviously been in government and been on Sage actually for a longer time period than I have, and he may have other comments he wishes to add.
No, I was about to ask Professor Whitty. Would you have any comments to add, Professor Whitty?
Well, I think only about two or maybe three, Lord Chair, if I may. I mean, the first is the great majority of science advice to government does not come through Sage. It is important to realise that is not the only route through, but the Sage mechanism, which was originally set up largely under Sir John Beddington and then his successors, I think was a vast improvement over what was there before. Because what it allows is lots of groups to feed in, and then several science disciplines and individuals to challenge one another, but then a unified view to be presented to the Cabinet or to COBRA. So what you don't get is you get the variety of views being fed in, but you don't get an undigestible group of opinions being thrown into a Cabinet meeting. What you get is a single consensus view, with whoever is presenting it saying how wide the variation is around that. And then the other thing just to add is that some of the subgroups that Patrick talked about are set up just for this Sage, but several of them are standing scientific advisory committees. So for example, the nerve tag group is a standing advisory committee that looks at respiratory infections made up of independent scientists from around the UK. And that exists between emergencies, irrespective of Sage.
Okay, Professor Flynn, do you want to add anything? Professor Flynn, are you muted? I think you might still be muted, Professor Flynn.
Is that better?
Oh, that's better.
Apologies. I think the only thing to add is the Public Health England both sits on Sage. We put some of our experts onto that group, and we also prepare a number of the papers that contribute and contribute to the discussion within Sage. We also contribute to NerveTag, which is one of the groups that Professor Whitty was referencing. And we are there obviously as a source of advice to any other groups that may need it on relevant matters. Thank you.
Okay. So can I ask a question that comes up now with this biosecurity group? So what is the role of biosecurity group now vis-a-vis SAGE?
Shall I have a first go? Shall I have a first go at that?
Yeah, Chris.
I mean, I think that the new JBC group is going to be doing much of the operational work in collaboration with Public Health England, pulling together the epidemiology, providing information on a day-to-day basis. What it is not doing, at least in its current form, is the job that SAGE is doing at pulling together science from multiple disciplines for the wider epidemic. So it's very much where the science we fed in, for example, at the moment, trying to identify hotspots of infection, trying to make sure we get them properly delineated and the best advice can be given locally. That will be the JBC, the Joint Biosecurity Centre, and PHE, Public Health England in England, equivalents in Scotland, Wales and Northern Ireland. But the larger science questions still come through SAGE.
And if I may just add to that. Lord,
yes, Sir Patrick.
It's a very important distinction. SAGE is an advisory group. It's not an operational group. It's not a management group. It's not formulating policy. It's giving science advice on topics that cross departments and are of major importance during the emergency. JBC is an operational group. It is a science operations group, and there are many around government, and JBC is much more akin to the function of Public Health England, as Chris has laid out, in terms of being able to identify hotspots, being able to identify where numbers are going in the wrong direction, linked closely to operational delivery and action. And I think that distinction is really rather important, and there are many such operational science groups and other science groups around government, as Chris has said.
Okay, thank you very much. Professor Flynn, do you have anything to add?
Really just to say that PHE has some statutory responsibilities with respect to public health, and we're working very closely with the Joint Biosecurity Centre to offer the benefit of our experience and expertise to assist them in this matter.
Okay, Baroness Young.
We've already heard a little bit about how SAGE deals with uncertainty in scientific evidence communicated to the government. Perhaps you could describe how the process deals with uncertainty and how that is taken forward into the advice that you give to government, how that uncertainty is communicated to government, and whether there's any danger of groupthink as a result. How do you deal with iconoclastic views that are coming in from left field that may have some validity? Perhaps Professor Sir Patrick could start, yes. And then we'll go on to Professor Whitty.
I mean, the first thing to say is almost everything we've been dealing with in this crisis has been about uncertainty, because it was a brand new virus and knowledge of it was non-existent last year. And although it's in a class of viruses about which things are known, this one itself, of course, there was nothing known. So uncertainty is very often what SAGE has to deal with. Indeed, it's very often what science advice in government needs to deal with. And it's the expression of uncertainty which is crucially important. I think just on that point, it's very obvious that there is no such thing in this crisis, and indeed usually in all aspects of science, as absolute certain, here is the immutable scientific truth, take it. It is about a scientific process which learns and grows in information, and the expression of where we are during that process and the uncertainty that goes around that. So the way that we deal with that in SAGE may be mathematical. So there may be times when you can put some mathematical uncertainty around a problem and say, well, this is what we think is the answer at the moment, and here is the uncertainty boundaries around that. More often, it's not that. More often, we will be expressing our output in terms of low, medium, or high confidence in the evidence and try to describe what the evidence base is. Clearly, to go back to a point that Chris Whitty made earlier on, it's not helpful to just give a wide range of different opinions and say, here they are, take your pick. The point of SAGE is to try to coalesce that into a position with the uncertainty expressed. You asked the question about how we deal with differences and iconoclastic views, and SAGE is full of senior academics, and as you will well know, the chances of them all politely agreeing on something are rather low, and that is the point of SAGE, to hear different views. An example that I think has been taxing lots of scientists in the UK and elsewhere over this period has been, for example, on face coverings, where people have had strongly held different views, and there are different lines of evidence that you would consider. Some favour the mechanistic work, where you're looking at droplet deposition on masts or transfer through masts or airflow. Some would favour more randomised clinical trials as giving you the answer as to what this does in real practice. And some would say, well, actually, it's the observational data when you introduce these into a new system and see what happens, whether it's a new country or a new time during an outbreak, and look at the outcome. And people hold strong views about the different information that comes from those. And those are the sorts of discussions that form the basis of a SAGE debate, which we would come up with in terms of then trying to express at the end of that what we think the position is and where the outliers are, so that it's clear to policymakers what the range of opinion is. But as I say, what we will not do, and I don't think it's helpful, is just to say, here's a range of opinions, take your pick. We try and formulate it into an agreed position where we can.
Believe that the questions that you're asked by Cobra or whoever sufficiently expect a range of uncertainty, or do they sometimes get couched in a way that asks for a degree of a single view to be expressed? Some of the modelers said that on occasions they were being asked for a single line on a graph rather than a range of possibilities. Is that because politicians can't cope with ranges?
Well, it is true that there's a process in making sure the questions are right, and so we do go through an iteration with Cabinet Office to make sure that we get the questions which are answerable questions and not overly precise. And we will reject things where somebody is looking for a point-specific answer on something where we simply do not believe there is a point-specific answer. We won't go back with that. We'll say, look, this is not a possible thing to do. We will give you the range and the uncertainties, which I'm afraid is the reality that needs to be dealt with. Of course, you know, many people would like to have a very precise answer. Is it X or is it Y? And there's very seldom is the case where we can deliver that. So we do go through a process of trying to make sure that the questions themselves are ones that are amenable to answer by scientific method.
Can I just add two things to what Sir Patrick has said? I mean, the first of which is that still now, and even more at the beginning of this epidemic, one of the points of uncertainty was we simply do not know. So when we started off with this epidemic, we did not know at all whether there might be any immunity, and if so, what sort. We did not know whether there might be people who had symptoms before, who actually were infected without any symptoms. And part of the things we had to say was, these are things we cannot give you information on because there is actually no data, and therefore the uncertainty is complete. And secondly, that we may well be in a situation where, and almost certainly will be, in a situation where we will have to change what the current view is as new data comes in. And that is a very important part of trying to get policymakers to understand the level of uncertainty they're dealing with. I think the final point on a single line, just to pick up your exact question, very often the difficulty is presenting very complicated data visually, and often a single line has to then be explained by the scientists in the room to the people who are making the decisions to avoid just providing data that is not easily interpretable in the context of a decision-making process.
Whitty, is there any risk of groupthink caused by the need to develop a consensus? Do you think that submerges disagreement in an unhelpful way on occasions?
Well, I mean, sorry, Patrick.
Go ahead, Chris.
Well, I think that risk is absolutely always there, and I think this has rightly come up in some of the things which people have, when they've looked at what's gone right and wrong in governments in multiple occasions over multiple countries. Groupthink is one of the biggest risks. So it is very important that we actually do have people inside challenging, but also people outside challenging. And personally, I very strongly welcome that when they do so in a way which provides logical argument, data, arguments backed up by science. Those are extraordinarily helpful. Obviously, when they just turn into a rant, that becomes less helpful, but enormously helpful having strong external challenge as well as internal challenge.
Yes, I was going to make exactly the same point, that I think it's important that we do get that external challenge, and it was very welcome that the Royal Society set up various groups to try and look at similar things as well, and we worked to help make sure that got set up. And we go to the other academies. The Royal Academy of Engineering has been incredibly helpful on things, and the Academy of Medical Sciences recent report on winter, which we commissioned, again, just helps make sure that we get a diversity of views into this. And I think if you look at the number of scientists who are involved across SAGE and the subgroups, it's over 100 in total, different groups. There's clearly quite a lot of challenge in that system, but in any system, groupthink, of course, is a risk, and it's something that needs to be guarded against. I think that external challenge is important. And as Chris rightly said, it's important that the external challenge, in this context anyway, is scientific and based on evidence and science. It's not terribly helpful to have external policy challenge into the science, because those are different points, and that's not really the issue.
Okay. Ernest Young, you're done? Thank you very much. Thank you very much, Ernest. Lord Winston, I was going to ask for slightly brief answers so I can get through all the questions. Lord Winston.
I've got so many questions, Lord Chairman, but anyhow, we've heard, just to come back to something that Chris Whitty was talking about, we just heard the modelling evidence produced in different countries is largely similar, but the interpretation of the evidence has been different. And in what ways do you think the evidence has been interpreted differently in England compared with other countries, and why?
Who would like to start?
Well, shall we ask Professor Thin, because you haven't had a word on this yet.
Okay, I think if I can use base coverings as an example, many of us are all considering exactly the same evidence. However, if you look at how that's actually translated into practice, you get some countries who are not even recommending base coverings, such as New Zealand, Australia, and Sweden. In other countries, it's mandated indoors. In some other countries, it's actually a requirement for children and teachers attending schools. So they're all looking at the same evidence, but depending on both the cultural and the societal norms, they are then translating that into a policy which reflects their society's norms. So I think it's not a simple solution. The evidence, I think, speaks for itself. However, it's the interpretation on the policymakers, I think, that makes the difference.
Maybe I could come then to you, to Sir Patrick and perhaps Professor Whitty, because, for example, one of the issues that we've just been talking about are face coverings. And this, to what extent has this been interpreted differently in England? I'm particularly interested to know whether or not, for example, a wet mask or a disposed mask is a danger, or for that matter, of course, obviously wearing masks. So we see a lot of people who are wearing masks, really what we would regard being as inadequate if it was in a medical situation. Can I ask Chris Whitty first what you think about the public acceptance of this aspect of limiting the virus?
I think, if we're talking about masks specifically, so just to build on what Professor Finn said, the stronger the evidence and the more clear the evidence, the more similar the response tends to be. That's just an observable fact across a whole range of different areas. But you've also have got to translate it into people buying into it and understanding what it is they're supposed to do. And you're right that there are important but relatively technical variations in face coverings that are used in the general public. Clearly, the kind of surgical masks you see in a medical situation, even more the respiratory masks for high-risk procedures, they are very, very highly regulated. But we're talking here about face coverings elsewhere. But the variation in those is much less important than getting people to do the basics. And the basics are, if you're going to wear one in a high-risk area, it must cover your nose and mouth. Wearing a brilliant mask covering half your mouth, only your mouth or only your nose, clearly is only going to have very limited effect.
But isn't one of the issues about public acceptance? Perhaps I could ask Sir Patrick about this. If the issue is public acceptance, and surely the biggest chance of getting public acceptance is if it's good for me, for my protection, rather than for other people's protection. Certainly, for example, you take track and trace, and unless in fact you're going to be able to diagnose the thing quickly and therefore treat somebody quickly, there isn't a great advantage in the person being traced. And isn't that rather similar in a kind of way with all the sort of protective things we're doing, where it might protect the rest of the community, and how we get that message across? I think that would be interesting to hear that from both of you, really. Sir Patrick.
Yes, I can talk about this, and then I think it is important that Chris or Nick talk about it, because this is obviously public health advice. But
sure.
You're right. Many of the measures are about protecting everyone else, and in that sense, similar to vaccination very often in terms of creating protection for others. So this is a classic public health issue, and the communication needs to be clear about what benefit this brings, and face covering wearing is a classic one where there may be some protection to the wearer, but there's more protection to others. And that's got to be clear in the message. I do think, though, that one of the things that we've seen during this crisis is the extraordinary altruism and spirit of the British people to actually want to do things that help other people, because many of the measures that have been introduced are actually about helping each other. And so that, I think, is a classic public health issue that I think maybe Chris or Nick want to comment on, but you're right in the question.
So I absolutely want to just support what Patrick has said. The extraordinary altruism of the British public is what has allowed us to turn the tide on this for now. But there are very, very many things we're going to have to continue to do. And I think a very important one, for example, is that if people have symptoms, they absolutely, of cough, fever, or losing taste or smell, they absolutely must immediately self-isolate with their households if they have one, and get a test so that their contacts can be identified. And that is absolutely critical. And that is an extraordinarily altruistic act. It's enormously inconvenient, and yet people do it. And they do it because they know that if they had the virus and they passed it on onto a chain which ended up with a vulnerable person who then died or became very ill with it, this would be a very bad thing for society. So it relies, the whole system relies on the extraordinary altruism of the British public, which they have completely risen to and will continue to.
Well, that's the point, Professor Whitty. I mean, how can we stimulate that continued altruism?
Well, I think the key thing is that people have to understand why it is that this matters. So, people need to understand the reasons. So I think explaining to people that, look, the reason why you must self-isolate with symptoms is relatively straightforward. Most people would understand, I've got an infection, I might pass it on. That's quite normal practice, just ordinarily. Explaining that actually this virus can transmit early on before people get symptoms, that's a bit less intuitive, and that's the reason why households have to stay in isolation, and why we need to find contacts so they can isolate themselves before they get symptoms, because people can become infectious very often for 2 or 3 days before their first symptoms appear. So people need to understand the reason, and if they understand the reason, then the really clear evidence is the British public will do this to benefit others.
Okay.
Thank you very much.
Baroness Walmsley. I think you're on mute, please, Baroness Walmsley.
Thank you. How is scientific evidence balanced with other types of evidence, such as social or economic evidence, to make policy decisions? And how is conflict between the different types of evidence resolved? Could you say who is involved in that process? And to what extent are you, as scientific and medical advisors, involved in that process of balancing competing needs?
Professor Whitty, you wanted to come in.
Shall I take that one first?
Okay.
Well, on SAGE, we do have social scientists, and we have somebody from the Treasury who attends from an economics perspective. And as Chris Whitty has made clear right from very early on, and he'll speak for himself, the economic consequences of lockdown also have significant potential health effects. And so we've been very conscious of that as part of the discussions. Outside the deliberations of SAGE, of course, there is an entire economics team within Treasury working on this, and it comes together, to answer your question, in the Cabinet Office in terms of bringing together the different parts of advice to formulate into policy options for ministers. And very often, Chris or I or both of us have been involved in those discussions in order to make sure that the advice from SAGE has been properly understood, whilst the economic analysis and the economic side is presented as well. And the ultimate decision, of course, in terms of how you make the trade-off and the balance between these are ones for ministers as to where they wish to take that decision. But we try to make sure that the advice from both sides, or all the different areas, are properly articulated so that those decisions can be made, and Cabinet Office is where the integration for policy options comes together in most of the cases. It could be in a department, normally it's Cabinet Office. Chris, do you want to add?
Well, I think it is important to add for this particular epidemic, it is, we should be really clear that there is an incredibly difficult balance that the political leaders are having to make, where they're walking a narrow path where on one side we could cause enormous unnecessary economic and social damage, people being isolated, all the unemployment, all the things we read about in the newspapers rightly, and steer too far the other way, and we end up with the epidemic coming back and a second spike. Walking that path is extraordinarily difficult. And of course they have to integrate the social, the economic, and the scientific and epidemiological advice. We're providing the science and epidemiology side of this and some of the social side, but the economics comes from other areas. But as Sir Patrick says, almost invariably we will be in the room when the big decisions are going to be discussed and can present the data, but then it is ultimately for the senior policymakers to integrate these very difficult, competing, necessary points.
Thank you. Lord Chairman, can I quickly follow up?
Yeah, very quickly.
Well, Sir Patrick mentioned a moment ago the Academy of Medical Science report.
Yes, and Robert
Leckler
Leckler is listening. He's our advisor.
That's right. I must say I find it very, very concerning. So I wonder if I could ask the witnesses whether they think the processes that they've just described are likely to change at all in emphasis or in function or structure over the next 6 months if we have a second wave.
Very briefly, please.
Well, I think the process of integrating advice from different places will remain, I suppose, and I think that's appropriate. And clearly the report which we commissioned from the Academy, and is, I think, a really very good report indeed, lays out very clearly what the options are that need to be considered for winter, that has far-reaching implications right the way across Whitehall. And Chris and I wrote a letter after the SAGE meeting that we considered the report, drawing it to the very clear attention of lots of departments across Whitehall for them to start considering how they would respond to it. And that's where the integration of the different sciences come together, and policy will need to be...
Is that letter in public domain, Sir Patrick?
I don't think that letter would be in the public domain, but there's no reason why it shouldn't be. We simply drew people's attention to the report and asked them to look at it.
Okay, thank you very much. Banner Sheehan.
Thank you, Lord Chair. So we've had reiterated again that this is a new virus and that we've all been on a very steep learning curve. I wonder if the witnesses can say what pieces or types of scientific evidence have had the most influence on the way the pandemic has been managed in England, And what could have been the implications for the course of the pandemic if this evidence had been available or indeed been considered earlier?
Chris,
Who
do
would
you want
like to start? Professor Finn, you don't seem to get a word in edgewise. How about you start?
Thank you very much. I think one of the factors that has played an important element is the realization about the extent to which asymptomatic infection is present, and also the potential for people without symptoms to transmit the virus. Early on, we drew parallels with SARS and with MERS, Middle East Respiratory Syndrome, which are derivatives or derived from the same virus as the current COVID-19. And we drew parallels with that, which, broadly speaking, concluded that people would tend to be infectious once symptoms were present. Now that we've a greater understanding and it's clear that asymptomatic transmission does occur and that people are asymptomatic, this is a significant change in the approach that we have to take. And we've seen that in the way that personal protective equipment is now being recommended, both in healthcare and in other settings. So I think that's been quite a significant development.
Thank you. So Patrick, would you like to add to that? I think you're on mute still.
lots of areas where this has been important and new knowledge is accumulated. I'll just highlight one, which is quite early on, from money that Treasury made available to Chris Whitty and I. We funded a genomics consortium to start looking at the genomics of the virus. That turned out to be extremely important in terms of being able to see the origins of different outbreaks. Were they linked? Were, for example, hospital outbreaks due to patients catching it inside hospital or from outside? It became important in terms of knowing where the importations came to from the UK. And one of the things that was seen as a result of that work was the seeding of the infections in the UK largely came from importations from Italy, Spain, and France, not from where people might have thought of initially, which would be obviously China and the East. So that sort of information is important. It really determines, I think, how we might behave going forward in terms of some of the activities, and importantly, the notion that you can use near real-time sequencing to understand outbreak relationships, I think will be an important way in which this is managed going forward. So I think there are lots of examples like that where science has emerged quite quickly and has turned out to be operationally rather important.
Thank you. Professor Whitty.
I'll just take an example from clinical practice, because obviously there's trying to prevent people getting the infection through managing the epidemic, but there's also managing the disease. And it is clear now we've learned a huge amount about how to manage it. Things like what's called proning, where people, when they're very ill, are laying on their front. The very important role of stopping people getting clots, what's called thrombosis, which we didn't realize at the beginning. But I think the one I'd really like to highlight is the recovery trial, which the UK ran right from the beginning, the largest trial of therapeutics in the world on COVID. And it came up with this really critical finding that the steroid dexamethasone, which is widely available around the world, very cheap, its safety profile very well known, significantly reduces mortality for people with severe disease. And knowing that will reduce mortality around the world because this drug is available everywhere. So that, I think, that's been a very important change, and I hope there will be several more to come. We're still continuing with trials of therapeutics as well as of vaccines.
Great, thank you.
Thank you very much.
May I ask the second half of my question, Lord Chair?
Please go ahead.
Yes. Professor Finn, thank you very much for bringing up a asymptomatic issue. I think colleagues further on will actually be asking questions on that. And I just asked, to what extent did evidence from previous pandemics or pandemic preparedness exercises inform management of this pandemic? And just to finish off, how has important evidence on the role and efficacy of PPE and face coverings, which we've touched on, but if you could just emphasize whether the evidence in reducing transmission, how important that has been for informing Public Health England's ongoing response to the pandemic.
Professor Finn.
Thank you very much. Thank you very much. Clearly, the pandemic that we were all preparing for was a potential flu pandemic. But fortunately, there are many similarities between the way that flu is transmitted and the preparations that one would put in place. So therefore, we had well-rehearsed, well-planned exercises where we tested our response, what we would do. We had a stockpile of personal protective equipment, which proved invaluable in this particular incident. And therefore, that preparation actually stood us in very good stead when the COVID-19 pandemic occurred. In terms of PPE, we've relied very heavily on evidence produced by WHO and by colleagues across the world in terms of what is the most effective types or forms of PPE that we can use to protect our staff. But I think it's really important for people to be aware that personal protective equipment is probably the lowest of the hierarchies of infection control that we normally refer to. First and foremost,
is that comment you just made quite scientifically based, that it is the least protective in terms of transmission?
Yes, it is. It's a recognized hierarchy that the environment is probably the most important factor, such as ventilation, structural design, etc. We then move into systems such as cohorting, identifying patients so that you're managing them separately. And then we move on to personal equipment, which, because it's absolutely reliant on people using well, can be one of the areas where problems can arise. Having said that, we do, the personal protective equipment that has been advised is to a high standard and is supported by both the Health and Safety Executive and colleagues in infection control.
Okay, Baroness Rock.
Thank you, Lord Chair. Professor Whitty, you talked about this narrow path that we're walking in terms of economics and health, and I'd like to come on, if I may, to the easing of lockdown, which we have been seeing since mid-May. And I wondered to what extent are efforts being made of how we're balancing the easing of restrictions with interventions that suppress transmission to keep the overall transmission low. And is the effect of transmission being modelled each time a restriction is lifted? Professor Whitty.
Thank you. So, I mean, there are some things which we started right at the beginning, which absolutely have to continue for a prolonged period of time. Washing hands, isolation, household isolation. And then we've added to that things like contact tracing, most recently face coverings. And these are issues of and issues around distancing, which have been varied, but the reality is distancing remains an important part of this mix, and how it's interpreted in different environments has evolved, but it has not gone away. So all of those need to continue for a long period of time. Clearly, as we remove, so the things which have been removed are largely in the group of things which was around a different aim, which is not around isolating individuals, but was around trying to break contacts between individual households. And several of those have now been lifted, not all of them. And we've tried to do that in a phased way, and the phasing was continuing as the Prime Minister laid out this morning, with some things right at the end, which we know from other environments, nightclubs as an example he gave, are associated with significant outbreaks. But we have to be completely clear that getting the exact balance right, so that we neither stay overly locked down with huge damage to families and their long-term health through that, or open up too fast And some countries have tried this, and they have appeared to maintain their level of transmission at a very low level, continuing to go down in some cases. Others, doing actually quite similar things sometimes, have tried this, and then there has been an upsurge in the virus subsequent to that. So we are obviously trying to go cautiously, and the question is, have all the things that we've got, which are countermeasures, provided people are really systematic about them, provided they continue to do all those things, provided we continue that, will we be able to continue to open up the society, open up the economy, but without leading to the force of transmission going above 1, and therefore going back to where we were. And I think going back to a previous question and the comment about the Academy of Medical Sciences report, we think that there are probably, or I think there are probably, and this would be, I think, is a very common view among doctors and scientists who looked at this, a group of things you could do probably for 3 seasons of the year, but it may be that in winter this is more difficult because winter so benefits respiratory viruses. That's why we get the flus and the colds and coughs in winter. So we do have to accept we may be able to do things for a period, and it's possible that in winter we may have to do some other things. And I think we just have to be honest about that. And the Prime Minister, I think, made that very clear this morning.
Thank you, Professor. Sir Patrick, I wonder if you could maybe have anything to add, but also just to look at and give us a feeling of what assessments are made on a community transmission, and what restrictions would be introduced at a local or perhaps even a national level, as Professor Whitty talks about going into the winter months.
Well, let me deal with the sort of science aspects and then ask either Chris or Nick perhaps to deal with the practical aspects of what's going to happen with that. But the first thing to say is, I think as you release measures, as Chris has said, it is inevitable as you get more contacts that you will see more cases. I mean, that's what happens, and that's therefore a consequence of anything that's done to release measures. Now, at the moment, we're in a position where things stay low and they look okay, but I don't think looking around the world that you would say you would rest on your laurels on that and assume that's going to be the case. So the critical question is measurement and detection as early as possible, and understanding how to react to it. And the model that you can see around the world and here is that the most likely thing is that you get an increase in local outbreaks, and those local outbreaks may be very local, which you need to act on quickly and deal with in a way that's proportionate to whatever's happened, so that you don't end up with sort of widespread lockdowns or measures to try and deal with that across the whole of society, when in fact the problem is local. So that's, I think, the way this goes. But as Chris has said, come winter, the challenges will be very much greater. And of course, there is a risk that this could also need national measures as well. In terms of what you can look at, the R value is decreasingly useful as you get down to local levels, particularly when the incidence and prevalence of the disease is low. So just to make an absurd example, if there were only one person infected and they then infected 5 other people, the R value would be 5. Yet you've still only got 6 people. So R jumps around when numbers are low and is not very useful for the local monitoring, and neither are growth rates. And therefore, you need to look at absolute numbers, incidence, prevalence, and a number of other measures that you might take as surrogates of whether there's virus out there, which is exactly what the JBC is set up to try to do. And I'll leave it to others to explain how that works as a system.
Professor Finn, what involvement would public health have in this local outbreak?
We work very closely. Through our local health protection teams with local authorities, the NHS and others, firstly to identify surges in activity or outbreaks, and then working jointly with them to take measures to try and control and stop these spreading. So we have this local to national perspective, where at national level we're there to provide support, and locally that liaison, that operational response is available. I think a key point has just been made a moment ago, which is to say that as we move into the winter and as things start to relax, the key point has to be the early detection of surges and prompt action. And that is what Public Health England and the JCB will be doing in the forthcoming weeks and months. Early detection, rapid response.
Okay, Baris Rock, are you done or are you?
Thank you, Lord Chair, I'm done.
Okay, Baris Manningham-Buller, please.
Thank you, Lord Chair. I want to ask the panel about the big strategy for this pandemic.
I think your sound is Baris Manningham-Buller.
I will try again. I want to ask the panel about the strategy. Can you hear me now, Lord Chair?
Yes, we can.
The strategy for managing this pandemic. I think we've heard from the evidence so far that there's an expectation that that could change during the course of the winter in response to the Academy of Medical Science report. But I'd like to ask the panel how confident they are that we will continue with broadly the same strategy, amended at the edges during the winter, or are there going to have to be significant changes to the current strategy?
Who would like to start? Professor Whitty.
Thank you very much. I mean, this is so. The first question is: do we, over the next 6 months, end up with some very different tools at our disposal that actually change our strategy? And obviously, the one that we would all love to see is if in the next 6 months we got an effective or fairly effective vaccine or highly effective drugs. I think Patrick and I certainly would be very surprised if that was the case, but very pleasantly surprised, and we're working as fast as we can to achieve that. But clearly that would lead to a significant change of strategy. I think the second thing is we are learning the whole time, not just from our own experience, but the experience of other people around the world. And Patrick and I both talk to our opposite numbers in many other countries to learn what's working and what's not, and read a bit behind the headlines, because what you read in the newspapers and what actually is the reality are often quite significantly divorced from one another. I would be very surprised if our strategy in 4 months or 5 months' time was identical to the one we have at the moment. I mean, the bare bones of it will be the same. We will still be wanting people to isolate if they have symptoms and have contact tracing. We'll still want them to have the measures which protect others. We'll, like face masks, we'll still be needing to have some local outbreak responses. But what we need to do in terms of the wider strategy and how we can do the maximum damage to the virus with the minimum damage to our society, that is going to evolve over time. And some of that is from learning from other people, and some of that's as the science emerges. So I do think it will evolve, and I would be, our strategy now is quite different to what it was 4 months ago, and I think it'll be different again in 4 months' time. Patrick may have a different view.
No, I don't have a different view. I do think there's an overarching principle, which is to try and keep the levels of infection as low as you can, and that remains the overarching aim up until the time you have something like an effective therapeutic, where you might change that. But until that time, and particularly going into winter, it's incredibly important to keep levels low. And winter, for all the reasons we've alluded to, is going to be a very complex time where the vast majority of people, of course, who end up with the symptoms may not have COVID, they may have something else. And so there are going to be people potentially being isolated for reasons that are non-COVID. And so it's a complexity which is going to be difficult to manage and may necessitate changing in the way we think about various approaches.
I have a couple of other additional questions, one of which I'd like to put to Professor Finn, which was, whatever the strategy is now, and I'm sure you could all three of you articulate it, and the expectation that will change, are you confident, Professor Finn, that the coordination between you, the NHS, what you're hearing from the centre, and from the new Biosecurity Centre, that's all, I hope, well coordinated and working together? Could you confirm that?
Yes, thank you very much. The Joint Biosecurity Centre is a fairly new entity, and we're working very closely with it to ensure that we have the links that we've got the joint working, that we're avoiding duplication, and most importantly, that there is clear line of sight between us around where the operational responsibilities rest. We have seen the formation of a variety of closer links, both with local authorities through directors of public health. There has always been a very close relationship with health protection teams and local authorities. We're now building on that to make sure that we have this local to national perspective that enables us to take action quickly and promptly should issues arise.
Thank you. My final question, I think I can guess the answer to it, but I'd like to hear what the panel think, which is, we've heard some countries plan to eliminate, quote unquote, the virus. Is this a credible option at any stage, even with a vaccine and or better therapeutics and earlier diagnostics? I'm asking you to speculate, but I'm quite interested in the answer.
Can you hear that, all right?
Yeah, shall I first go at this?
Yeah,
please. I've had the privilege of
Professor Whitty.
working for many years with diseases which were slated for elimination, so I thought about this quite a lot. I think it is very important, if we're going to talk about elimination, to be precise. So very low numbers of cases, get us absolutely as low as we can, as Patrick says, is absolutely what we should be trying to do. Elimination means something quite specific. It means 0 cases other than imported ones, no onward transmission inside a country. Now, if you think about this virus, which has got a very common syndrome, asymptomatic travel, millions of cases around the world, very easy to transmit. Lots of countries have tried to keep it out. Very few countries have succeeded in that. I think trying to eliminate this, particularly if you're a highly connected country like the UK, London's one of the most highly connected, probably the most highly connected cities in the world, is quite optimistic. So the difference between elimination, 0, and very low is in absolute terms, in terms of numbers of cases, very small, but conceptually it's very, very big. And I think some of the people who are calling for elimination may actually be meaning good control, but I do think in science it is important to be precise. Elimination means 0 cases onward transmitted, and that's going to be, for this disease, this is going to be very difficult. I would just draw to the panel's, to the committee's attention that we've tried to eliminate or eradicate a very large number of diseases over the years. We have so far in humans eradicated 1, smallpox, and we've tried on a lot of other occasions. This is not an easy thing to do.
Thank you very much, Professor Whitty.
Thank you very much. Lord Mayor.
Thank you, Lord Chair. From a public health perspective, can you say more about the difference between managing the pandemic in a centralized manner, as has been done in England, compared with the benefits of decentralized management with greater involvement of local public health authorities? Perhaps Professor Finn, you could start.
Okay, thank you very much. I think it's important to get the balance. Over-centralization can lead to people having a sense of local ownership, and what we need at the local level is coordination and as working to common principles and guidance. So I think what we provide at the moment is surge. We can provide additional support, as was the case in Leicester, where a team went to assist the local team in assessing the situation and coming up with suggestions and recommendations. But what's really important is local teams have that liaison, the good working relationships, without which we can't translate policies or advice into action. So it's the ideal situation is the balance between good centralization and good local engagement.
And we've heard already mention of the very important report from the Academy of Medical Sciences about the winter. Could you say more about the capacity? Does the UK have the local public health capacity for more decentralized management of the pandemic when winter comes? What's your view on that?
Well, winter comes every year, and therefore we have well-established plans for responding both to flu, to norovirus, and a variety of other viruses that we tend to see creating problems both for the population and for the health service. I think it's fair to say, however, that probably if you were to look at our accounts in Public Health England over the last 6 to 7 years, the budget that's been allocated has reduced probably fairly substantially. This has meant that we are more efficient, we are more effective. However, what that's done is taken away the capacity to serve resilience that we perhaps had several years ago. So there is an issue of how that additional resilience is built into the system, and this will be very important if we're to deal with surges in the future.
Professor Whitty, would you like to add?
I concur with that, and I think the fact that so much resources had rightly to be put into the JBC is because of this fact that we really have not invested in health protection over the last several years in the way I think that would have been ideal to set up a completely good structure that would allow us to do that. And I think we should all be honest about that. I'll just add an additional point to Professor Finn's point, which is that when you're at the beginning of an epidemic, when it's a very large scale epidemic and the same broadly everywhere, a national response actually is usually the most effective way to deal with that. The more we get down to this later stage with much lower numbers, very, very different problems in different places, the more local responses are absolutely critical. So the national resources should be there to support the local response, but it should be the local people, the directors of public health, the local authorities, that for most of these small outbreaks, which are very much to do with the particular environment they're produced in, they should be taking the lead with support from national resource. It's absolutely critical we do that. And I have to say, I speak to the directors of public health every week. They are a really impressive group of people, but they need to be resourced properly to do what is a difficult job and will continue to be a difficult job as this epidemic goes through.
Thank you. Sir Patrick, anything to add?
I concur with what the others have said, and it's worth just reflecting maybe as an example of that. I think the countries that invested heavily in their public health systems following the MERS outbreaks have done well, and they had the right systems in place. So I think it's important to invest in this. I agree with what has been said about the importance of local management of this, and therefore the importance of public health on the ground in these places, and the appropriate investment at scale, which allows that contingency planning. I mean, this is something which isn't going to be used at full capacity the whole time, but needs to be there to be able to get surge capacity when you need it, and that requires investment which has not been there.
Thank you.
Thank you. Professor Whitty, being pedantic, is there a scientific difference between elimination and eradication?
Yes, there's a very important difference. Elimination is, generally speaking, taken to be 0 cases, and I mean for prolonged periods in a geographically defined area. Eradication is eradication around the world. But elimination is obviously, you need to eliminate virtually everywhere before you can even think about eradication. But there's quite a lot of attempts to do elimination which have started and been found to be very difficult. I want to be absolutely clear, when Patrick and I and many other people say we want the lowest number of cases, we would be delighted if the lowest number of cases was 0. But it's whether strategically you are aiming to go for 0 and keep at 0 for this kind of disease. There are many other diseases where elimination is the right thing to do. Eliminating rabies from the UK was the right thing to do. Eliminating malaria from the UK was the right thing to do. But this is a disease which has got a very large number of differences to those kinds of infections.
Professor Finn, you're trying to get in.
No, I have nothing to add.
Okay. So Patrick, you referred to what we need is a stronger public health system. We're not going to get it soon, but are we likely to be able to strengthen it anyway before the winter storm, or if there's a second wave comes?
Well, I think, again, that's really questions for Nick Finn or Chris Whitty, but as Chris has alluded to, I mean, the investment in the JBC tells you, and the test and trace system tells you, the level of investments required to have that degree of surge capacity and the skills, the capability you need to do that. So I think this is an important
what is the investment in
across public health.
What is the investment in JCB?
I don't know the number. Chris or Nick might, but I don't, I'm afraid.
Professor?
Sorry, Nick?
I'm afraid I don't know I don't have the number.
In the budget, it was around about 9 billion.
Okay, that's a significant amount of money. Sorry, Professor Flynn, you want to comment about something?
Yes, it's really just to say, and this is something that some of us have experienced in medical education. It's quite, when we start to see assumptions made about reducing or public health services is not attracting the investment, and people will not tend to go into recruitment or will not tend to go into training. And once that happens, trying to reverse that is a big job. You're talking about 5 to 6 years of training. So it's not something that you can say, we need more consultants, we need more scientists tomorrow.
We need more training.
Yes.
Yeah. Professor Lord Kaker.
Thank you, Lord Chairman. I'd like to turn to the question of a potential re-emergence of this disease later in the year and try and determine whether there is scientific evidence that speaks to that potential course in the natural history of this pandemic, and to what extent the current approach that we're taking towards suppressing the disease now in July and August is impacting on that potential in terms of any modelling or other information that you have. Maybe I can start with Sir Patrick.
Yes, thank you. The first thing to say is that I think the re-emergence that we're seeing in many countries now on lifting of lockdown should not be seen as a second wave. I think it's a re-emergence of the first wave. And that is the risk that when you've still got levels circulating, you release the measures, things come back. The question of will there be subsequent waves, I think obviously is by definition an unknown, but I think everyone that I've spoken to thinks it's highly likely that this disease will continue to circulate and will come back in waves, and it may well be seasonal. And perhaps some of the things happening in the Southern Hemisphere now might support that. If it's the case that it goes round the world, comes back again, then clearly we remain as a population exposed to this, we're vulnerable to it, and therefore the measures of reducing contact to reduce spread, the sorts of social distancing measures that we've talked about, and the hygiene measures that go along with that will be necessary. So the modelling has suggested from the beginning that the risk of a second wave is high, and there is a very significant chance that it comes back in force in the way that the first wave did, and we need to be prepared for that. But of course we don't know, and we are much better prepared in terms of our understanding of the measures that need to be in place to try and deal with that. But I think we should be alert to this as a very high probability. Is it this year? Is it next year? I don't know, but I think it's likely that we will see future waves of this.
And you quite rightly, Sir Patrick, make the distinction between re-emergence of this first wave and a new second wave at some time in the future. How does the epidemiology of disease over these coming months and the approach that's being taken to suppressing the disease, taking the break off lockdown, inform or help us predict what that early re-emergence of disease potentially in the coming months look like? Is there any understanding of that?
I don't think we have a clear understanding of that. I will make one comment, and Chris may want to comment because this is very much his area. But I think that something that is important is the higher the numbers in circulation when you go into winter, the higher the likelihood you get a significant peak. And that speaks to the importance now of getting our numbers down and getting on top of this with the measures that are in place.
Professor Whitty, I know if you can pick up on that, and also what evidence has been available, modelling evidence to SAGE in terms of interventions, policies, guidance that could have the greatest impact in terms of reducing levels of transmissions in terms of this specific re-emergence?
Thank you. I'm going to take some examples because I think they are important to think about them in isolation. In coming into trying to deal with the first wave that hit us, and it was quite on quite a broad front, which is one of the reasons we got to where we are. We had to do a very large number of things at a point we didn't really fully understand all the forms of transmission of this virus. I think we now have to break that down into lots of different elements and try and work out which are the ones, because what we've got to trade off between is which, with the ideal things, are things that have a very significant reduction in transmission, but very little impact on society. And there's a kind of abatement curve between those two. And there are some important components of that, and I'm just going to use one for illustration, and that's schools. Now, on the positive side, we are very confident that children do not very commonly get the severe disease and very, very rarely die of this disease. So one of the good things about this virus is virtually nothing else good about it, is it relatively spares children. So we're not worried about children going to school because of safety, but a school is a way of bringing together lots of different households. And there is a very strong debate among different countries which are taking different approaches to this, Germany, Scandinavia, China, and so on, about what is the role of schools in transmission. Because all of us agree that education of children is absolutely critical. So if we can send children back to school and have little impact on the virus, then actually we can probably do it relatively straightforwardly. We may, however, have a situation that when children go back to school, we may have to put in other measures to make up for that. So these kind of trade-offs between different sorts of tools we have to reduce viral transmission, each one of which comes at a social cost, that is putting together the optimal package for this particular virus. And that optimal package may be slightly different or very different in the winter compared to other months. We don't know that yet because we haven't yet got data from that. This virus started at the tail end of the winter, except in China, and into spring. So we haven't yet had a full 12 months to actually see how the seasonality works.
Professor Finn, if I might just, in that context, look at the question of testing capacity and whether, in terms of re-emergence of the disease in a few months' time, there is sufficient testing capacity appropriately deployed to be able to best mobilize measures and interventions to prevent this from taking hold substantially across the nation.
I think Professor Finn, you're involved with the Biosecurity Center.
Yes, I think what we've seen is we're in a very different position now than we were in January. I think it's important for people to be aware that Public Health England, we provide our reference services, we provide diagnostic services for new emerging pathogens and unusual diseases. What we don't do is provide testing at scale. So we were involved in the initial development of protocols for testing for COVID-19. Those have now been developed. These have now been developed at scale within the NHS, within the private sector, within academia, and therefore we're much better prepared. I think the Prime Minister today has announced an expectation of 500,000 tests a day as we move into the autumn and the winter time. In addition to that, we're seeing additional methods being developed. One of the exciting possibilities is a study being undertaken in Southampton where they're looking at using oral fluid as a very quick and rapid way of testing individuals. We've also seen a better understanding of the virus influence some of the policies we hope to adopt, which is going to be the frequent testing of potentially high-risk groups and offering that more widely in the population. The idea being that we'll detect those people that are potentially asymptomatic or pre-symptomatic and can take steps to stop spread at a very much sooner period than has been the case before. So I think there are a lot of things going into the winter and mean that we will be better prepared. and testing capacity will be one of those, and we expect to have the capacity that will enable us to do that.
Lord Caker.
Thank you, Lord Chairman.
Okay. I think I know Lord Irwin.
Yes, thank you, Lord Chairman. Sticking with the winter, what assumptions are being made about the transmission of SARS-CoV-2 in the winter months, and what evidence are these assumptions based upon? And what assessments being made about the combined impact of winter respiratory illness and COVID-19 on the health system? And is there anything that you would advise that we could do now to mitigate this combined impact? For instance, expanding the flu vaccination program.
Who would like to start? Professor Whitty or?
Okay, I shall have a first go if you would like. In terms of evidence in the winter, the evidence is indirect. As I said in answer to a previous question, and we haven't been through a full year in the Northern Hemisphere yet, and different respiratory viruses tend to have a slightly different seasonality. So we can't be absolutely certain on this. But I think given that so many respiratory viruses are benefited by the winter, including the common cold coronaviruses, but many others as well, I think that we have to assume that it'll be benefited by the winter and then be pleasantly surprised if it is not. So I think that's and that's for good and obvious reasons. People are crowded together, ventilation is much less, they don't go outdoors as much, there's less strong sun, it's colder temperature, so virus is maintained longer in the environment and so on. So there are perfectly good biological reasons why that happens. Of course, you're absolutely right that there is both a combined potential biological impact and there's definitely a combined practical impact, because the NHS, like every other health service, is under much more strain over the winter months. And that's partly due to flu and other respiratory infections, but it's due to many other things as well. It increases some cardiovascular disease, trips and sprains, and all those sorts of things. So the NHS is under stronger pressure. So the combination of those is going to be considerable. In terms of flu, you're absolutely right. One of the things we can do, in addition to making sure there is more capacity this year in winter, which was talked about by the Prime Minister today, is to expand the flu vaccination programme and to make sure that we have this as extensive as we can, it probably extending downwards from the current ages and upwards from the current ages, although exact age bands are still being determined. Now, there is a but to that. One of the things that's been very striking in some of the data, early data from Australia, early data earlier this year from Hong Kong, is that when people started socially distancing for coronavirus, flu rates went down. So it may be that some of the things that we're doing for coronavirus may have some benefits on this side, but I wouldn't want to bet on it. So you're absolutely correct that we should be investing in the flu vaccination program to the best of our ability this year.
Sir Patrick.
I've got very little to add to that. I agree completely. And I think the only thing I'd say is that we should think about treatment for flu as well. So there are drug treatments we should think about, whether they get used more widely. And the final additional point was, it may sound odd, but we don't have good evidence of the transmission routes of this virus. And indeed, we still don't really have great evidence for transmission routes of flu either. And so some work is starting on understanding transmission routes. And that's going to be important because in winter, of course, we're in different environments as well. Indoor environments, much more likely. Understanding what the environmental conditions are which facilitate transmission will be an important part of managing this over that period as well. But I think Professor Whitty has dealt with the medical aspect.
Can I just add something, Patrick, because I think someone might have misunderstood your answer. That we are very confident that droplets are important, and we're very confident if you touch a contaminated surface and touch your face, that's important. The ratios between different routes of transmission, droplets, touch, possibly aerosol in particular environments, those are what we don't understand. But these broad routes are I think, broadly uncontentious.
No, absolutely right. So those three routes are important. But my point is, understanding those in specific environmental settings is important to understand in practical terms the transmission. Sorry, you're absolutely right. Thank you.
Professor Finn?
Really just to To add to what's been said, it's highly likely that we will see an increase in coronavirus. Each year, the common cold, we do see a surge in activity along with flu. Everything we can do to reduce a flu admission is one extra admission that might be available for another patient. So very active programs around encouraging people to be vaccinated and to encourage healthcare workers to get vaccinated will be absolutely key. We are putting in place or enhancing our surveillance systems, both for flu and for coronavirus, to try and detect patterns or trends that might enable policy decisions to be made. Just to build on what Professor Whitty said, I just received a report that said that Australia has seen a 95% in flu this season compared to last season. And a lot of that will be attributable to measures that have been taken to deal with COVID-19. So we have some very tangible evidence that there are things that we can do to control this.
And just for those who are not aware of this, the flu season in Australia is the opposite way round in the year too here. So that's now.
Yeah.
Professor Finn, you referenced the project in Southampton, which, as I understand it, uses the RT lamp method, which is a saliva test. It's relatively inexpensive and it takes only 20 minutes to get the results. Do you see that being expanded around the country so that we can have what a paper that was published by the Royal Society asked for, which is mass testing on a regular basis?
I think the study that's been undertaken in Southampton, which has started and is now underway, is really quite exciting. What it does offer is two things. One, a very simple way of getting samples to the laboratory. And yes, potentially using this technique, we get a very rapid turnaround, which is what we need if we're going to control transmission. It's about identifying cases early, isolating them to prevent further cases. That's the key. Getting a result a week later, really, we've missed the opportunity, and this sort of rapid turnaround will be vital. And if successful, this will be rolled out further.
Thank you.
Okay.
Thank you.
Thank you very much. Baroness Hilton.
Yes, we seem to have moved into the testing and tracing arena. What is the evidence that test and trace will actually have an effect on suppressing transmission and reducing infection rates? What is your evidence for the effectiveness of test and trace? It's probably Professor Finn, I suppose.
Thank you very much. Identifying cases and then identifying the contacts is a well-established public health measure that we deploy to control a number of infectious diseases. Being able to identify the cases and the contact means that steps can be taken to stop transmission and therefore ultimately control the spread within the environment. One of the key issues, I alluded to it in the previous response, was getting test results quickly so that we can advise those that are positive and their contacts to actually self-isolate and prevent transmission. There has been a paper produced by the Royal Academy of Sciences which suggests the contribution of test and trace is around 5 to 15%, and that's on top of other measures such as social distancing and good hand hygiene. And while test and trace does have a contribution to make, you should not be, it's not the only thing. We need to be constantly emphasizing the social distancing and hand hygiene as important measures to be taken.
Thank you. The ONS data suggests that only about 25% of cases are being traced. Are you confident, therefore, that it will be effective in light of that?
25% is still a significant number. Clearly, there are opportunities, and this project is not static. it is evolving. But this is a responsibility that currently rests with the Department of Health, and I know that work is going on to improve and enhance that.
It has been described as a safety net for underlying the release of people from lockdown and so on. Do you see it as being an effective safety net or just a contribution?
I think it's a definite contribution. We mustn't forget that the key measures here are self-isolation for those that develop symptoms, and people using social distancing and hand hygiene and other measures to prevent both catching COVID-19 and spreading it to others.
So Patrick, do you have any contribution to make on this point?
The only thing to add is that, of course, as a high proportion of people appear to be asymptomatic, and we still don't know exactly what that proportion is, but it seems to be a significant proportion. It's very difficult to identify those people, and of course impossible for them to self-isolate because they don't know they've got it by definition. And so identifying them through contact tracing is important. So the contact tracing, the fact that the current system is picking up whatever percentage it is, it may be picking up a rather high proportion of the symptomatic people. You would hope that by doing so, you start to get a higher proportion of the asymptomatic people as well, because you're now containing them as contacts. And as you start to test in high-risk environments where we know spreading is occurring more easily, or in high-risk occupations where people have much more contact and therefore higher chance of getting it, then you start to pick up asymptomatic people as well. And I think that's the trajectory that needs to be, we need to go down in order to get on top of this. And it's going to be particularly important, obviously, where you see outbreaks, that you get on top of this in this way as well.
Thank you very much.
Okay. Lord Brown?
Thank you, Lord Chair. So this is still on testing and tracing, and this question, which I'll ask in two parts, conscious of the time, is to explore what the science and the evidence tells us about test and trace capacity and how we should deploy it looking forward. So the first part of this question is, I mean, is there evidence to support the expansion of test and trace to first-degree contracts, or even to undertake backward contact tracing, to go more deeply into any one identified person who's infectious? And does the evidence suggest a role for preemptive screening, for example, in identified local populations or high-risk workplaces, in order to try and I suppose chase down the infection?
Professor Whitty.
Professor Whitty. Okay, thank you. So the answer to balance, so I'll take those in each in turn, because I think for all of them there's some evidence, but there's more evidence for some than others. Backward contact tracing, I think, is increasingly, we think, an important thing to be able to do, and the aim of the test and trace system is to be able to achieve that. And I think one of the things that is clear, and was not clear at the beginning of this epidemic, but is much clearer now, is that this disease is passed on in clusters. This is one of the things that, for example, the Koreans have demonstrated really well, and the Chinese as well. So that you might have a situation where the great majority of the transmission comes from about 20% of the people who get it, the rest really don't transmit very much, and it's a particular environment. So backward contact tracing to find those environments and then go back to find who's been to those environments is something we should be aiming to do. And the lower the transmission rate, the easier this is. Second question you asked, or third question bit, I'll come to the first one last, is around preemptive screening of particular errors. And of course, we already do that in quite a number of environments. For example, people coming into hospital, people transferring into care homes are already screened. And if there's an outbreak in a hospital, if someone's in a high transmission setting like Leicester at the moment, then we would recommend increasing screening, for example, of asymptomatic healthcare staff. And that's the direction of travel. How far we will go on that, we're trying to determine at the moment. And we're doing a number of studies to try and ask the question, actually, what's the pickup rate and how much does this contribute? But absolutely, there will be groups we want to prospectively screen, and there may be some particular high-risk groups. For example, it might be, and I'm not it's singling this out, I'm just giving this as an example, transport workers like bus drivers or taxi drivers. We might think this is an appropriate thing for us to do, but we need to get the evidence. And I think one of the things that can be slightly problematic is lots of people say you should be doing this and doing that, but we've really got to get the evidence as to what works. And doing that now when the incidence is low, relatively speaking, I think is an important thing to do. I think expanding to first degree contacts, there is now enough evidence of pickup, we've got to answer that question. And I think if you'd asked me that a month ago, I've been quite skeptical. I'm much less skeptical of this now. But I think, again, we need to work out who are the groups where that's going to be useful. Because in test and trace, the first degree contacts are already being isolated. They're contributing to reducing the transmission. They're protecting their neighbours by, when they're contacted, isolating. So the question is, what are we going to get in addition in terms of disease interruption by testing the first degree contacts? And is that going to give us more benefit than we've got with our current system? And I think the answer to that we will know in weeks to months, but we don't know it yet. And I think it is really, I go back to my first point, it's really critical we're evidence-based about this. We base it on data and we base it on proper modelling rather than doing it rather randomly, because it's very easy to use an awful lot of tests and achieve very little if you're not careful.
I don't know, either of the other witnesses wish to say anything? So can I just ask a very quick supplementary, perhaps for Professor Finn? So what does this say about, capacity for of testing, and tracing going forward? What are the implications of this sort of thinking for that? Because presumably we would want to have the capacity to be able to respond properly if the evidence revealed that this was the right thing to do.
Yes. If I could just, before I answer that, I could just go back to a point that was being made about contact tracing. Contact tracing is something traditionally we do with diseases like TB, with other infectious diseases where we're trying really to track down the source. One of the potential issues with COVID-19, and which is why it's really important that we pilot and we test this, is that it's actually only present for a relatively short period of time, in people that are infected. If someone's got TB, for instance, they have it until they're treated, and therefore you've got a longer period of time in order to identify them. So the challenge is that you can probably go back to first degree contacts, but going back any further becomes challenging, and we must see results of the pilot to see how effective that will be. The second thing, I completely agree, if we're going to go down this route of increased testing, both in high-risk settings or in groups, we need to ensure that we have the capacity to do that. And I am aware that plans are being put in place to expand testing capacity, and I believe a figure of 500,000 tests a day has been quoted, today as the target that we're aiming for going forward. But it is essential, if we are to implement these strategies correctly, that we have the testing capacity to back it up.
Okay, thank you very much. Thank you, Lord Chair.
Okay. Sorry, Lord Borwick, not Baroness.
Thank you, Lord Chairman. I want to ask about the potential impact of computerized contact tracing apps on iPhones or whatever. Am I right in feeling that that is becoming less important now that in Britain the incidence is going down? Is it becoming harder to actually activate in Britain? And indeed, is there a computerized app that has your confidence at the moment? Professor Whitty?
Well, the short answer to the second of those questions is that at this moment in time, no. Or we would have deployed one, but that is something which the aim is to develop that. And we've kind of had, I've not been involved in development, to be clear. I'm reasonably good on what you can use it for. I'm much less good on how apps work. I suspect actually you're better than this, than I am. in terms of that particular technology. But I think we should be aiming to have this as an additional part of our armamentarium, because we do, to go back to what I think all of us are saying in different ways, this virus will only be dealt with if we do very large numbers of things. And having an app that's available, particularly for if there was a surge, if there was a new wave, or in winter, this will be an important additional thing we can do to pick up cases early. But I'm an old-fashioned public health epidemiologist. I'm used to doing contact tracing the old way, and that's where we started. It's development of very, very established practice, but apps are a new way in which we can do this faster and pick up contacts we otherwise would not know about. So that's the big advantage they potentially have. But of course, there are operational issues and there are privacy issues that need to be completely sorted out before we could be confident we could use that.
So Patrick?
Well, I agree. And I think the 2 points that Chris has raised are exactly right. This is about speed of contact and about identifying contacts who you otherwise wouldn't have realized had been your contact, i.e. somebody who's been with you in an appropriate environment or inappropriate environment for 15 minutes or longer. That's where this is going to be useful. But there are all sorts of issues that come with that, including privacy ones and technical ones. But the app could definitely be an advantage if it could be used in that way. And I think it's important to recognize it would have to be very widely applied, because unless everybody or a vast majority of people are using it, it's really not going to add that much. So optimistic modeling of this says if 30% of people had the app, it would give you 9% more contact identification. To give you some sort of feel for this.
So really, you see, we should use this period of the pandemic to develop the app, to make it more useful in the event of a second wave.
Yes.
But the trouble will be getting people to take it up if they don't come across any infected individuals. I mean, people, if you can persuade people to install an app onto their computer and look at it and cope with all the privacy cases, and yet they never actually have come across anybody, they're going to object a little, aren't they?
Well, I don't know, but you're absolutely right. The uptake of this is going to be the challenge. How do you persuade people to use this? How do you persuade people that their rights are protected during this? And how functional it's going to be? But we do need to use the time now to try and get this right. And as Chris Whitty has said, it's not as though there's a off-the-shelf one that's working very well somewhere else yet that's being used at scale across a high percentage of the population. So I think there's a lot still to be done, but it could be very useful, I think, if done properly.
Although, to be clear, several countries have got versions, and I think we should be learning from them as well.
So we have got closer to it than we were, say, 2 months ago.
Yes.
In your opinion.
Yes.
But we're not there yet.
And to just on your general point, my lord, I think that my ideal would be if I would download it as a civic virtue and hope it never went off. So this time of year is not the time of year when, with low incidence, many people are going to be being contacted by it. But of course, the reason to have it is to make sure that the unknown contacts are contacted as early as possible.
Indeed, and that everybody is ready, yes.
Okay.
Okay.
But I think, Baroness Young, you at one time were asking why don't we adopt apps that are already available. Baroness Young, you want to comment on that?
Thank you, Lord Chairman. There are apps elsewhere. We seem to be struggling a bit with the technology to develop our own. Why don't we just ask for somebody else's in the spirit of global cooperation?
I mean, I'm probably the closest to this of the three of us, but I'm not very close to it. I think I will give you a bad answer. So rather than me give a bad answer, I'm sure we could get, you could get someone who actually is much closer to the app development. This app development is not my skill.
Thank you.
Professor Finn, do you have a comment?
No, no, I'm going to agree with everything that's been said. This is not an area that I'm familiar with. I'm a traditionalist. I'm very much in the same camp as Chris Whitty. The one thing I would say is that those at highest risk of acquiring COVID as contacts will be those that are usually known to the individual. In other words, household, work colleagues, close friends. The additional benefit that one might get from people that are unknown, there will be some, but it will not be as big as focusing in on the high risk groups.
Okay, thank you, Baroness Blackwood.
Thank you, Lord Chair. Professor Whitty, quite early on in our session, you said that there is clear evidence that people will take action to protect others when they understand the reason why they're being asked to do things. But as we move into the next phase of this pandemic and we move from really national action to localized action, that will become a more complex picture. I mean, we're already seeing in Leicester, for example, people in one part of Leicester being asked to do one thing and in another part, they don't have to. And so providing the evidence and the data down to that level to explain and communicate very clearly the justification for those kinds of requests, I think will become even more important. We've had a few difficult moments, I think, in recent weeks with the Pillar 2 testing data and of course with the PHE urgent review which has come out. So I just want to ask for an answer around the confidence around providing the public with the data and the information which they need to understand why they're being asked to take action at a local level as we move into this next phase.
Thank you. I mean, I think that the data we're providing at a local level is a lot better this week than it was last week, and it'll be better next week than it is this week. So I think when my public health colleagues in directors of public health and others say, you know, early in this epidemic, and in fact until relatively recently, we were not really getting the data we needed, I think there is sufficient justification for them to say that. Increasingly now we're able to provide those data to them at a very local level, so they need to understand it operationally. But you can now go on to Public Health England websites and get very good maps of exactly where things are, where the high areas of high transmission are, to a relatively high degree of detail. What we have tried to do is avoid, and this is at the request of Directors of Public Health and others, going right down to postcode levels or other things that could lead to privacy issues, although those data exist. But in terms of trying to make it clear so that people, you know, because people should know their own data around the area. And so it's a very fair ask. And as I say, it is improving the whole time. The data are now there. It's a matter of presenting it in a way that is intuitive and people can see their area and the areas around them and understand the data that is present. You know, I think any feedback people want to give as to how to improve it, we would be very keen to hear.
Thank you, Professor Whitty. So, Professor Finn, do you think that directors of public health in a local area would now be confident that they have the data that they need in order to operate effectively with the powers which they've now been given in the way in which they would be expected to do by citizens?
Yes, I'm much more confident now than perhaps was the case a few weeks ago. But I mean, throughout this pandemic, directors of public health have been supported by the local health protection team, who would have had access to some of this information and some of this data, you know, at that early point. It's been a complex process. We've been having to talk together numerous data sources. That's been achieved, I think, fairly successfully. And so I'm confident, and from what I've heard from colleagues, that they now feel they have most of the data they need in order to manage these situations.
But I would like to stress that if a director of public health says they don't have enough data, we listen very seriously to that. I don't think we would want to brush that aside at all.
So there was a word that worried me there, most of the data. So there are bits that are missing still. When do you think we'll be in a position to say local directors of public health and local authorities who have been given the power to respond have all of the data that they need?
Sorry, I may have misinadvertently used the word there. What I meant was the quality of the data. The data is there. The data that coming from the NHS and the PHE laboratories, over which we have a lot of control, we are assured of the quality of that, and it's of a high standard. There have been issues about the completeness of some of the other data. So it's not that it isn't there, it's the completeness of some aspects of it. Nevertheless, what is being provided is sufficient to be able to judge whether there is an issue in a locality or a potential outbreak.
Okay, thank you. I also wanted to follow up on the interaction between national intervention and local intervention, which is likely to become more relevant as we go into the winter, as we've discussed, and to understand how those decisions will be coordinated. I think just today, obviously, the Prime Minister has announced, for example, that the shielding programme will be paused. And that seems like a likely intervention that might be reintroduced in the autumn. And so I'd like to understand how the coordination will work effectively, given that some of those coordinating measures were quite challenging at the beginning of the pandemic. I don't know who would like to pick up on that first.
Shall I go? Because I think it's more up. Oh no, Nick, why don't you go first, and I can add if there's anything additional.
Professor Finn, yeah.
Okay, I mean, this is one of the key roles of the Biosecurity Centre. They will be making those operational roles that we will be looking for in terms of understanding and controlling local incidents. So they will be the group advising on what measures could be taken and supporting the local response as we go forward. So if I can maybe pass back to Chris. On that.
Well, I think the one thing just to add on that is you asked specifically, Baroness Blackwood, about the shielding programme. And that was initially designed around our quite limited understanding of risk factors, so it was relatively crude. We now have a much better understanding due to research done in the UK as well as data from other countries. And so we'll be reviewing the way that we do that, and we hope risk stratifying in a much more accurate way if we need to do it again. Obviously, we hope we don't. And to go back to Patrick's point repeatedly, we want to keep very, very low levels. Professor Finn has talked about the Directors of Public Health, the local authorities, PHE and the JBC. There's an additional group who are very, very important in this from the professional side, and clearly then there's the public as well, and that is GPs. And I think if we were honest, we didn't manage our communications on this with GPs ideally, and we've learned from that, and we hope we will do that better if we have to do another shielding version.
Thank you. I just have one final question. Given that going into the autumn and winter, the decision making will be more complex because you'll be dealing with the local and the national potential measures. Can I ask what lessons have been learned about transparency around the scientific decision-making process? This has obviously stimulated a lot of public debate, and we did open this session with discussions around SAGE and structure. It's going to be more complex in the winter because you'll have local decisions being made, you'll have JBC, and you'll have national interventions. And so what I'd like to understand is how can that be reflected in a model of transparency so people can understand the scientific advice processes and the basis for the measures which are very consequential for individuals, and we can maintain that level of altruism which has slightly been referred to. Perhaps Patrick, you might want to come in first.
Yes, well, I think we definitely made a mistake earlier on by not getting the SAGE minutes and papers out quickly. And that was, in a way, an historic thing. That SAGE has been a subcommittee of COBRA, and traditionally papers didn't come out until after the event was finished, and then they were subject to screening in order to release them. For this, it was right to get the papers out and make sure people could see the evidence on which decisions would be made. And so I think that's an important lesson to be learned. And of course, as always, the speculation before the papers were released about what was in them and also who was on stage was far more exciting and fruity than the truth when the papers were out, when people can see the nature of the scientific work behind it. I think you're absolutely right that going forward, that is, if you like, the science advice side of it, where we need to get that clear out in a timely fashion so people can understand what's informed policy decisions. And you will know very well that ministers will need time to consider things before the policy is formed, and therefore it's difficult to do that well in advance of the policy, but we should try and get it out at the same time at least. But I think on these other aspects of local data, as Chris and Nick Finn have said, it's really important those data are there for people to be able to see the basis of decisions, which are the ones that are going to affect them more. And hopefully we will avoid national decision making for lockdown, and this will largely be a local phenomenon. But I think the transparency point is important in all of this.
Yeah, I think so. Can I just add to that? I mean, I completely agree with Patrick that it was an error not to have got all the data out early on Sage. I think if I can do one thing just to alert people who are interested in data, the UK is very fortunate that the Office of National Statistics and Public Health England data forms are actually excellent. And for those who like data, you can lose yourself for hours in chart after chart, and indeed the basic data behind it on both those sites. And I would encourage people who want to look at data to look at it there. It's world class and really clearly presented.
Does that mean that for future pandemics, or to that matter, winter, second wave, that we would be able to use this data epidemiology-driven policy making rather than modeling?
Well, I think, I mean, I don't think, I think that's a false dichotomy, as some of my colleagues would call it from the philosophical side. I think we clearly will need to look at straight data, and for outbreaks, you don't need a model to tell you you've got an outbreak in a factory, in a hospital, in a town. Modeling, though, will continue to be very important for trying to do forecasting and for merging together data from different areas to do some forward projections at an operational level, and for looking at the potential impact of different interventions. Patrick may want to add to this. So I wouldn't want to see them as one or the other. I think we're going to have to use both for different things.
Okay, Baroness Blackwood, you done?
I am done. I think there is just one proposal that we've had in writing that I would just like to recommend to Professor Whitty and Sir Patrick, which is to consider the working protocols of the ACMD and the Investigatory Powers Committee, which has been helpful in ensuring that there is public understanding of the workings of those committees, and might be helpful for SAGE as well.
Okay.
Thank you.
I think Baroness Young, you had a question related to the winter and possible second wave. As to, you want to come in, Baroness Young?
Could I just ask, a couple of times during the evidence this afternoon, there's been a suggestion that as the level of the condition increases over the winter, maybe other measures need to be introduced. Can you give us a feel for what these other measures are beyond the ones that we've already seen?
Briefly. So Patrick or Professor Whitty?
Well, I'll make a few comments and Chris might want to come in. I think it's really about the response needed in relation to what the outbreak is. That's really what people are talking about. So it's not a whole load of new inventive ways of doing what we know needs to be done. In some ways, this is all very simple, which is breaking contact between people during times of an outbreak or an increase in numbers. How you achieve that, of course, may be somewhat different depending on the environment in which this occurs. And I think the aim would be not to have very broad brush total societal lockdowns, but actually to think about where it's necessary to do things at a local level and in a more sophisticated way to try and break the transmission. Chris, you may want to add to that.
No, it's basically exactly that, and it is around trying to get what we need to do to get on top of the virus with the minimum amount of harm, and that's really the balance that we're going to have to strike all the way through this. And minimum harm means the least damaging as an approach, and in the smallest area that we can manage it.
Okay, Lord Hollick, you had a question.
Thank you, Lord Chairman. One of the things that's puzzled me, and it goes back really to the very first question you asked about the communication between SAGE and the government, is that two of the organisations that are represented on SAGE, that is to say the Wellcome Foundation and the Royal Society, both closed their offices a week or 10 days before the Prime Minister decided to lock down. Was that information communicated to the government? Because I think that some of the behavioural scientists might comment that you not only need to listen to what the experts say, but watch what they do.
Well, that's certainly known. I mean, just a point of clarification, it's individuals who are represented on
Sure.
SAGE at meetings, not their organisation. So they're there as individuals. Yes, that was certainly known and known across government.
Okay, Lord Taker.
Thank you, Lord Chairman. I just want to go back to the question of testing and whether there has been any analysis or modelling of the different testing strategies that have been discussed this afternoon and that are being adopted in different jurisdictions around the world, and how those impact on the re-emergence of disease in terms of a test and trace principally based upon symptomatic individuals versus looking at a broad population-wide testing on a regular basis for asymptomatic individuals and varieties of strategies in between, and how those matters have been considered by SAGE.
So modelling of test and trace has been looked at quite a lot in terms of what degree of contact you need to identify and what impact that would have overall. And as has been discussed earlier this afternoon, we shouldn't think of this as a panacea that solves all of the other issues. You need to keep the other ones in place. But what we modelled, or what was the modellers modelled, was 80% identification of contacts, and then built on the impact that would have on the overall outbreak. And rather usefully, what they've done is to then put that into the context of a variety of other measures, because one of the problems with this approach always is you can look at an isolated thing and say, oh yes, that's useful, or oh no, that's not harmful to reopen this or to make that change. But this is a system-wide problem, so you need to be able to integrate what is the effect of the change I'm about to make in the context of all the other changes that might occur. So what they've usefully done is looked at test and trace in the context of other changes as well. And so we've got quite a lot on that, and it does reinforce the importance of this as a very key part of it. And others, as you're aware, will have modelled total societal testing. But of course, those things are not possible at the moment. And as Nick Finn has alluded to, it may well be that LAMP technology may allow that sort of thing to be possible. It may be much easier to do it, but we're not there yet in terms of practicalities of that approach.
But does
Can I add?
Sorry, does the modelling suggest that that is a reasonable target to pursue in terms of technology? Because if that technology and approach, technology were available, that broader population approach might be justified.
We haven't got good comparative models on the different ways to do it. And of course, it's a difficult one at the moment because the incidence is low, but Chris wanted to come in, I think.
Sorry.
Well, I think to conceptualize it, there are, we started off with very few tests, and that was for a number of reasons, largely technical, and we've expanded them out. Now, when we really had very few, there was a bunch of things we absolutely would have wanted to do, but we could not do it because we were limited by the number of things. But you go out from the things you absolutely have to do, starting with diagnosing severe patients and then milder patients, but then going out to healthcare workers, and you kind of go out, and the further out you go from that, the less clear the evidence tends to be. But we're moving out through those concentric circles. So to take, for example, asymptomatic testing of healthcare staff. The question is not whether you should do it. The question is simply frequency and who should you first target it on. The question about whole population screening is quite controversial, and there's models that suggest it's useful, and there are others who think those models are at the more speculative end. LAMP, on the other hand, has, let's leaving aside the question about whether whole population testing is an appropriate thing to do, which I think would need to be demonstrated because it's a huge undertaking to do. Doesn't mean it's the wrong thing. But one thing we do need, and LAMP might be able to help us with, is much faster testing, because we have got good systems for testing people who come in for elective treatment in the NHS. But what we want to do is have things that can give us very fast turnaround. So someone coming in as an emergency, you can isolate them, test them, and then release them if the test is negative. But that does rely on the test having a very high sensitivity, or otherwise that effect doesn't work. So it's those kind of areas, rapid testing, and LAMP may be helping us in those kind of environments, possibly.
That's the Finn.
Lord, sorry. But you'll have to be very quick because Lord Winston, I'm going to go to.
Thank you, my Lord Chairman. I just want to say very briefly that I think when we saw Chris Whitty and Patrick Vallance in front of the camera with the Prime Minister, certainly amongst my colleagues, there was a huge breath of relief to see you in front of the public in that sort of way. And we congratulate you on how you managed a very difficult task. But I do wonder, with these scientific issues, so often there are debacles. You take nuclear waste, you take crops which have been modified genetically. Constantly, we don't seem to get the trust of the public. And here, the public trust seems to be absolutely critical. I mean, Baroness Blackwood has just mentioned this, but I wonder if you could just very briefly give some indication of how you think we can encourage public trust in such an important issue in the future.
Professor Whitty?
Oh, sorry.
Sorry, Sir Patrick.
I think it does come down to openness, clarity of explanation, and I think also providing the clear link between what the science advice is in terms of its implications for policy and operations. I think that link is quite important.
Sorry, can I just add a positive point, which is if you look at polling data, trust of scientists, I'm not talking about government scientists here, I'm talking about scientists, is actually very, very high.
Yeah,
and I think that is something which we should make use of.
Okay, that's good.
Thank you.
Can I have a final word? It's about every country in the world, but certainly our European countries, would all be thinking now about the winter and a possible second wave. So how much collaboration or communication there is between us and you talking to them?
A lot is the answer. Chris and I spend a lot of time speaking to colleagues from other countries. We've got a big session with colleagues from Japan on Monday or Tuesday next week. We speak to our counterparts in various European countries a lot. And of course, needless to say, everyone is dealing with exactly the same issues, as you say, and trying to think about how to deal with them. And in January, I set up a call with international chief scientific advisors, which then the US took over. And that's been meeting on a regular basis throughout this with chief scientific advisors from 30 or so countries.
And can I just add on that? I mean, in addition to that, so I speak with colleagues from the WHO Euro region, who are our neighbours, but also the WHO as a whole brings together very usefully leaders, public health leaders from around the world. And then in terms of the 4 nations of the UK, I'm in contact with my CMO colleagues on a usually daily basis in one way or another, and we certainly stay very closely in touch.
Thank you very much. Well, I've run out of time. Lots of my colleagues still had lots of questions, and in fact, I stopped them asking some, which I'm sorry about. And I have no doubt you, 3 of you, also probably wanted to tell us more. I'm very sorry we run out of time, but thank you very much indeed today for coming to help us have this session. So thank you.
Thank you very much.
Goodbye.
Bye-bye.
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 The broadcast will end this session anyway, but we'll end this session.